Well, good afternoon. I'm Avery Nathens, and I am a trauma surgeon who is the Director of Trauma at St. Michael's Hospital here in Toronto. And one of my major interests academically is understanding how we can improve the access to care for severely injured patients. And why does this matter? Well, trauma centers are relatively few and far between. A trauma center is essentially a hospital that has all the resources to provide immediate care for the severely injured patient. And there are lots of studies that really emphasize the value of trauma center care. We understand that if you're cared for in a trauma center compared to a non-designated center, your risk of death is about 25% lower after serious injury. Not only is the risk of death lower, most patients do survive their injuries. We know that patients who survive with severe injuries tend to have a better quality of life if they've received care in a trauma center. And that's because the healthcare staff, the orthopedic surgeons, the neurosurgeons, and the trauma surgeons have a good understanding of how to work together and how to optimize the system within the hospital to provide the earliest possible care, as complex as it might be. We also know from cost-effectiveness studies that trauma care in a trauma center is more cost-effective than care in a non-trauma center. So it seems like there's a tremendous series of benefits: lower mortality, improved quality of life or functional outcomes at a lower cost for patients cared for in a trauma center. Well, what makes a trauma center a trauma center? It's interesting to note that among all the hospitals in Ontario, and there's probably about 150, 160 acute care hospitals, only 9 are designated by the Ministry of Health as a trauma center for adult patients. Now, one of the challenges, at least in our region and in much of Canada, is that trauma centers are typically located in the most urban environments. And that is somewhat problematic because injury is certainly as apt to occur in regions far remote from urban areas than they are in the inner city. And that means there has to be a system in place to get patients to trauma centers. So we focused on trauma centers and all their benefits. There's a large body of literature that looks at trauma systems, which is essentially everything that a region has put into place to ensure access to care. In Ontario, we have what's called an exclusive trauma system. Again, we have a small number of designated trauma centers, but no other hospitals have a plan in place to take care of the injured patient. In many areas with similar geographic challenges, the authorities have put into place inclusive systems, which means even smaller hospitals are designated as trauma centers but at a lower level. So the trauma centers in the inner city are typically level 1 or 2 trauma centers. They have all the resources to take care of the patient. What should be happening outside of the major centers is that centers should be identified as trauma centers at a level akin to a level 3, 4, or 5 trauma center. These are hospitals that have some resources and a plan in place to provide immediate care for the patient, which is essentially immediate resuscitation, evaluation, and then a plan to transfer the patient as expeditiously as possible. And I think what we're lacking in Ontario, at least, is that inclusiveness. I think that when you look at the data, there's certainly a lot of opportunity to improve. For example, we know that the mean time for a patient who is transferred from another hospital to get to a trauma center is in the range of about 5 to 6 hours. That's too long in a critically injured patient. We also know that about 40% of patients who meet criteria for severe injury don't actually make it to trauma center care, perhaps because providers believe they might not benefit, or perhaps because those who are providing initial care haven't identified all the concerning issues and therefore haven't transferred the patient to a higher level of care. The other data that is particularly bothersome is that we know that a number of patients die before they can receive trauma care. So if you look at all the patients who make it to hospital alive, about 22% of all deaths occur in emergency departments awaiting transfer to trauma center care. So if you look at all injury-related deaths, probably about half of them occur before patients arrive to hospital. But among those who arrive to hospital, 22% die before they can receive trauma center care. And we think that if we bring other hospitals into the system and provide them with the resources and the skills to provide immediate evaluation and management with expeditious transfer, we can probably save a lot of lives in Ontario.